anything? No, in which case, Mike, I'm going to go to you and the microphone's with you now.
Thank you, Chair. I'm sorry to say I'm back here. I've been flogging a dead horse since September of last year, I think, and fundamentally it concerns community health provision within the Felixstowe Peninsula, and I was recently contacted by one of the members of the 3 PPGs representing our 3 surgeries who have been in discussion with various bodies with regards to what provision looking forward will be needed, and there's been a deal of discussion as to how many dwellings may be being delivered across the Felixstowe Peninsula. The figure started off, I think, at 2,740. That's been amended now to 3,244. But figures I were able to obtain actually shows a figure of 4,197, which is a considerable increase on that number, but that figure is only based across 3 parishes of Felixstowe, Trimley St Mary and Martin. The other parishes, of which I currently represent, of which there are 11, are obviously contributing more residents, more patients for the 3 surviving surgeries that we have, making greater demand without being resourced. Now, what the PPGs are concerned about, it would appear that £782,000 has been approved by the local district council from the community infrastructure levy without any conversation, it would appear, with the 3 practices. And if you look at that figure for the potential 10,000 additional patients we're going to have coming into our community, that works out at about £78 per head. I'm not sure what sort of community medical health facilities you could be providing with such a low funding figure. And I think we need to look at Felixstowe Peninsula in its entirety. It does have a community hospital. You are looking to increase the population by 1/3. That community hospital really should be looked at in how it could be more effective going forward. It could possibly have a diagnostic hub attached to it. The X-ray machine that it had for years and years has been cannibalized to keep it functioning, met its death, I think, a couple of years ago. We really feel that there needs to be a broader look across our whole piece on delivering much more community health, which would remove pressure on our general hospital. More things could be done in the community. And this isn't only a problem of Felixstowe Peninsula. We have a significant building program going on at Maltisham on the BT site. We also have another development that will be happening at Saxmundham very shortly. And we need to get a grip, I think, of local government working with the NHS and others to do the best we can and to ensure the community infrastructure levies that are raised are actually used but are of the appropriate amount. So I don't know whether we're in a position for this board to explain why only £782,000 was the figure agreed on when they didn't really know how many dwellings were going to be a part of the 2 local plans coming forward. That is over 23 sites, and they are building out at different rates, but 5 of the biggest are currently being built, being occupied, making demands on our surviving 3 cities. So if we could perhaps move forward. I know Maddie is in the process of making some meetings, so I'd be grateful for an update.
Okay, no, thanks very much, Mike. And just while Maddie thinks of how to answer that, there's a number of questions you're raising, from accuracy of numbers to provision of funds for whatever number, and to provision of resources and future planning. But also the really interesting point I think that you raised as well was around integration and working together and plan, which actually came up at the Health and Wellbeing Board in Suffolk that, we both attended last week, didn't we? And there was a great focus there on working together and integration between health and local authorities, which actually I was very pleased to hear. Yeah. So with that thread, Maddie,
yes,
over to you.
absolutely. Thank you very much. So thank you for that. So I'm really pleased to report that the demand and capacity planning work for Felixstowe and the broader communities into Trimley and beyond is nearing completion, and we have been in discussion with our district council colleagues, with our ESNEFT colleagues, our social care colleagues, in the integrated neighbourhood teams, and of course with GPs in order to get this position. And we have also now, as you know, received some really important feedback from the local community with the survey that was undertaken and led by them, and for which we're very, very grateful. So this has now been brought together, and we have a series of meetings over the coming couple of weeks to kind of check this understanding with the people that have participated so far, prior to a steering group meeting, and we've offered 2 dates to that, and to which you are invited, either at the end of August or the start of September, at which we'll be able to look at this position together and to look at what, therefore, the objectives and the priorities are for Felixstowe and the wider area. I should also, of course, have mentioned the Friends of Felixstowe Hospital, who are also have been engaged and have meeting, Nick, with your colleagues and the Friends in August also. So I think we are getting close to a position of understanding and of creating the forward plan together for Felixstowe, and that will come back to the Alliance Committee, and then we would be very pleased, I think, to bring it back to this board in public as well when we're ready. Thank you.
Okay, so work in progress to Alliance, then back to board. Okay, thank you. Nick?
As you know, we're always looking to see what additional services that we can provide in the community rather than relying on the acute site. I know there have been conversations around X-ray and indeed other issues for some years now. At Felixstowe, I'm very happy and keen to be involved in those ongoing conversations. I think, though, you make a very important, more general point. If we look at the growth of people living right across the ICB footprint, not least in Colchester, where we've seen an additional 30,000 people come in just in my tenure as Chief Executive there in 7 years, with an addition of no additional general and acute beds that have been funded. So I think there is a question that we need to be asking ourselves why we're absolutely driven to not rely on acute beds. It's not where people should be getting their care unless they need to get their care in an acute bed. There is no doubt that there will be the need for a growth in the number of acute beds, even if we are maximising the opportunities of caring for people in a non-hospital setting. There will be need for additional beds. And I think as a board, we need to be more closely aligned to the medium and long-term planning for the growth, which is inevitable and necessary for people in terms of additional housing. How does that reflect an investment right across the health and social care spectrum? But just now talking specifically about acute beds, so I think it's a really important point that you raised.
No, thanks, Nick. So back to that point about integration again with our local authority colleagues as well and working together. So.
Well, I think it's more than that, with respect, Chair, because I think it is, even if we maximise all of that, we do need, so we know that as in East of England, we have a deficit of beds per 100,000, and we know in certain parts of the East of England where we've got the greatest deficit in England. When you look at it, and no matter what you do around integration and investing in community and investing in primary care, which is absolutely what we should be doing, there will still be a need for more acute beds, and it's simply not being addressed anywhere, and it needs to be.
Okay, noted, thank you. I'll go Mike, then Frida, then Richard. So back to you, Mike.
I was just going to say the opportunity really for your organisation and many others is when the local plan comes off for renewal and review, because I've seen the two that Suffolk Coastal and now East Suffolk passed, and there's very little input from health, what we need to be doing. I think it's only 20% of our well-being and health is actually as a result of communal activity carried out by yourselves, and 8% of how well we are from other things, particularly local government delivering it. And it's not discussed, and it should be a key part of our local plans and this. Thank you.
Worth noting. Let's note that. So thank you. Frida.
Yeah, I just going on. I was actually Nick sort of went with what I was going to say in some ways. Just how does the question to Maddie really? How does the Felixstowe development and what you're doing fit into the SNE primary care strategy overall? Because it's not just one area, is it? I mean, with all due respect, I mean, I think you highlight a really important point that actually is reflecting across primary care, across the whole region and nationally. And going back to the pie chart in terms of the amount of investment in primary care is so much less than acute trust. And I take Nick's point about always needing acute beds, there's no doubt about that. But nevertheless, we still need more investment in primary care to develop these ideas, because without the investment, it's all very well sitting in groups and talking and bringing up very, very valid points. But unless we have a change of that pie chart and further investment, then we can enact the primary care strategy, which will include Felixstowe, hopefully, and look at pockets of real deprivation of primary care, because that, there are some areas that are very well serviced and other areas that are appallingly serviced, and we need some equity in our planning. And I think Felixstowe just reflects one of the areas that is poorly serviced, perhaps. I don't know enough to be able to validate that, but certainly tendering my area is poorly serviced. So I think it's about equity and it's about a strategy across the area.
Yeah, being joined up. Let me go to Richard, and then Laura, did you want to come in? And Maddie, perhaps I'll go to you for closing comments. So Richard first.
Just partly sparked off Nick's comment about more broadly demand pressures on acute more broader. So you may recall, board members, that we commissioned a piece of work which Grant Thornton supported us on looking at a 10-year demand and capacity plan running to 2032. Alex Ryan, who many of you will know, who's our Deputy Director for Strategic Analytics, etc., came to the exec this week with some of the outcomes of that, and we were going to recommend that we actually, at our September board, have a development session around that. It's quite stark in terms of its initial findings around the pressures, unsurprisingly, if we do nothing over the next 10 years more broadly on primary care, community, acute care and social care. Even when we overlay the interventions that we've already agreed, there is still a significant gap, particularly 4 years hence. So we'd like to have kind of a conversation as a board about the so what. So we've got to make some kind of key decisions or pieces of work to get over that. Obviously, the work that Craig and team have been doing, the Future Systems Programme, is a little bit ahead for that part of the work we've described, because we've already got the interventions overlaid, but I'm aware there's still gaps in that in terms of what's expected versus what we've got now. So we thought that might be quite a good conversation for the board to have holistically around what do we think we should be doing in terms of what's shown.
Agreed. Let's take that forward, Richard. Thank you. Laura?
Thank you. I've been working with Maddie and Peter and working closely with Amanda's team around estates to very much look at the point you make around the health and care policies that sit within local plans, but really importantly the evidence base around that, because they have to be very robust. So really starting to think more thoroughly around health and healthcare impact assessments and how we use the evidence that we collectively can draw, not just from the data we hold, but from local authority to make sure that those plans are in place. I think there's 2 points to this. With new builds especially, it's also about making sure that we embed prevention principles in design. We've been working very closely in Essex with the Sport England local delivery pilot around active design principles and making sure they're embedded. And then, of course, as Frida says, it's also about the health and care provision that comes with that. So I think there's 2 approaches to this that we need to take. But I'll continue to work closely with Amanda's team to make sure we do this, and of course with Maddie and Peter as well. So there's wider work within the ICB ongoing as well. Thank you.
Thanks, Laura. So, Maddie, any further comments, closing comments?
Just a quick response to Frida's point. I mean, yes, they're absolutely inextricably linked, the kind of primary care, medical care forward strategy, and indeed, actually, the plans in terms of dental and pharmacy and optometry as well, in relation to workforce, digital and estates. And I think there'll be an update to the GP executive group this Thursday on where we are with that planning. Thank you. And just thank you to Richard. It's Alex Royan that's helped us with some of the demand and capacity work in this piece. Thank you.
Great. Thanks very much, colleagues, and that was a very useful final debate to have. So thank you very much.